This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the European Stroke Journal, published in 2026. It's the Joint Guideline on Aneurysmal Subarachnoid Hemorrhage, or aSAH, produced by a powerhouse trio, the European Stroke Organization, ESO, the European Association of Neurosurgical Societies, EANS, and the European Society for Minimally Invasive Neurological Therapy, ESMINT.
This is a document we've been waiting for, Alara. When you see the ESO, EANAS, and ESMINT collaborating, you know you're getting a 360-degree view of the pathology, from the neurologists and stroke physicians to the open vascular surgeons and the interventional neuroradiologists. The lead author, Mervyn Verpaven from Utrecht, along with Nima Edmanen, Peter Vaikacci, and the rest of this international committee, have really tried to harmonize how we manage one of the most critical conditions in our field.
Exactly. And for our listeners, residents, and fellow surgeons, this 2026 guideline represents the current gold standard. Looking at the author list, we see a heavy emphasis on conceptualization, data curation, and methodology. This wasn't just a group of experts sitting in a room sharing anecdotes. This was a rigorous, evidence-based deep dive.
Right, and that's a key point for the residents. When we talk about aSAH, we aren't just talking about a bleed. We are talking about a complex physiological cascade. Dr. Verpaven and his team have structured this to cover the entire patient journey. Alara, where does the guideline start?
It starts with the fundamentals of the diagnostic workup. Even in 2026, the speed of diagnosis remains the primary prognostic factor. The guidelines emphasize the need for rapid imaging and, importantly, the multidisciplinary decision-making process. They really lean into the fact that the management of the aneurysm itself, whether it's clipping or coiling, needs to be a collaborative choice between the specialties represented by EANS and ESMINT.
That's a crucial takeaway. In the past, there was often a silo mentality, surgeons wanting to clip, interventionists wanting to coil. But this guideline, being a joint effort, reinforces that the patient's angio-architecture, clinical grade, and age must dictate the modality, not just which specialist sees the patient first.
And speaking of modalities, the guideline goes deep into the timing of intervention. We've always known that early is better, but the 2026 data curated here reinforces the push for ultra-early treatment to prevent rebleeding, which, as we know, carries a catastrophic mortality rate.
Let's talk about the authors for a second. You see names like Torstein Melling and Peter Vaikacci. These are giants in open microsurgery. Then you have the ESMINT representatives focused on the minimally invasive side. When they agree on a recommendation for, say, a wide-necked middle cerebral artery aneurysm versus a posterior circulation aneurysm, that carries immense weight.
It does. And I think for the residents listening, it's interesting to look at the methodology section mentioned in the paper's metadata. They used a very structured approach to investigate the literature. This helps us navigate the gray zones of aSAH, like the management of the elderly or those presenting with poor Hunt and Hess grades.
Did the guideline touch on the management of delayed cerebral ischemia, or DCI? That's always the black box of subarachnoid care.
Yes, that was a major part of the investigation and writing roles for authors like Raymond Hellbach and Michael Hugelshofer. The focus remains on nimodipine as the standard of care, but the 2026 guideline really refines how we monitor these patients in the ICU. They discuss the shift towards more nuanced multimodal monitoring, rather than just relying on transcranial Doppler or clinical exams alone.
That's vital. We are moving away from one-size-fits-all and into a more precision neuro-ICU era. The fact that this is an official guideline from all three societies means that these monitoring protocols should ideally become the standard across Europe and beyond.
Dr. Aris, one thing I found interesting in the author contributions was the role of formal analysis by Leonard Ho and the data curation by the rest of the team. It suggests that they really looked at the long-term outcomes, not just a 30-day survival. We're talking about quality of life, cognitive outcomes, and return to work.
That's the real frontier, isn't it? Saving the life is stage one. Stage two is preserving the person. These guidelines from 2026 are clearly trying to bridge that gap. For a practicing neurosurgeon, this document serves as a roadmap. If you're in a multidisciplinary meeting, a stroke board, or a vascular round, and there's a debate about a complex case, this is the paper you pull out.
And for the medical students or junior residents, it's worth noting the geographic diversity of this group. You have expertise from Utrecht, Barcelona, Bucharest, Mannheim, Innsbruck, Zurich, Helsinki, and Copenhagen. This isn't just a single center perspective, it's a continental consensus.
It's also interesting to see the minimally invasive aspect highlighted by ESMINT. As technology evolves, our definitions of minimally invasive in neurosurgery are constantly shifting. Whether it's advanced flow diverters or new intrasaccular devices, this 2026 guideline ensures that these are integrated into the standard treatment algorithm alongside traditional microsurgical clipping.
Exactly. It's about having every tool in the shed and knowing exactly when to use it. The paper mentions the conceptualization phase was led by many of the senior authors, including Nima Etminen and Gabriel Rinkel. Their historical perspective on how aSAH research have evolved over the last 2 decades really grounds these new recommendations in reality.
Let's pivot to the practicalities for a moment. If a resident is on call tonight and a patient rolls into the ER with a thunderclap headache, what is the 2026 takeaway from this ESO, EANAS, and ESMINT document?
The takeaway is high sensitivity imaging immediately, rapid referral to a center that can offer both clipping and coiling, and a multidisciplinary assessment within hours. The guideline also stresses the importance of standardized protocols for blood pressure management and the prevention of secondary insults before the aneurysm is even secured.
And once the aneurysm is secured?
Then the focus shifts to the DCI window. The guideline provides a very clear framework for fluid management, avoiding hypovolemia, and the targeted use of induced hypertension if DCI is suspected. It's all about maintaining that cerebral perfusion pressure.
It sounds like the 2026 update really reinforces the idea of the comprehensive stroke center. You can't just have a surgeon, you need the whole ecosystem. The neurologists like Ana Ramos Pacon and Eliana Owana Terracosa, who contributed to the original draft and reviewing, represent that critical neurological oversight that happens both before and after we are in the OR or the angio-suite.
Absolutely. This paper is a testament to the fact that neurosurgery doesn't happen in a vacuum. The writing, review, and editing process for this guideline was clearly extensive, ensuring that the neurosurgical perspective, EANS, and the interventional perspective, ESMINT, were balanced with the overall stroke management perspective, ESO.
Before we wrap up, Alara, any final thoughts on why this specific 2026 publication is a must-read?
It's the level of evidence. When you see methodology and formal analysis listed so prominently in the author roles, you know the recommendations aren't just opinions. They are based on the latest randomized control trials and high-quality observational data. For anyone preparing for board exams or looking to update their hospital's internal protocols, this is the definitive source.
Well said. It's about elevating the standard of care across the board. Whether you are in a high-volume center in Berlin or a smaller unit in Romania, these guidelines provide the evidence-based backbone for what we do every day.
And it's a reminder that even in a field as established as neurosurgery, we're constantly learning, constantly refining, and most importantly, constantly collaborating.
A perfect place to end. To our listeners, get your hands on the European Stroke Organization EANAS and ESMINT guideline on Aneurysmal Subarachnoid Hemorrhage 2026. It's available in the European Stroke Journal.
Thanks for joining us on the Neurosurgery Hub podcast. I'm Dr. Alara.
And I'm Dr. Aris. We'll see you in the next episode.
Stay sharp.
And keep operating.